as as a fellow in training. Dr. Nora Goldschlager once was putting it together, and so I've been involved in California ACC for a long time. It's nice to see how it's grown. Currently, I give you my background. So after training, I went into private practice for about 12 years with a 7 person cardiology group. And then about 10 years ago, I transitioned to Kaiser just because, market changes, different opportunities. So been at Kaiser for 10 years, and I've been doing government relations with Kaiser Permanente for about the past 8 years. And that's really helped me, get experience in terms of doing government relations. And I've known Tim since I was a fellow too. So he's been with our organization for a long time, and it's really great having him on board and continue to help us through all this challenging times.
Thank you so much, Dr. Wong. And then Tim, maybe you want to, can you go ahead and introduce yourself before we get started with the slides?
Sure, I'll do a quick intro. So, Tim Madden, I really appreciate you allowing me to join the session tonight. And I am the lobbyist for the California chapter of the American College of Cardiology. So, I am based out of Sacramento. I do have a small lobbying firm, so we do have some other clients. I am all in the healthcare space, which is great. But to Dr. Wong's point, I've been working with the chapter since 2004 when I first started lobbying, and our firm has been working with the chapter going back 30 plus years. So we have a long history in working with the organization on a myriad of issues impacting cardiovascular medicine. So really excited to be here and looking forward to the discussion.
Thank you so much. And then Dr. Wong, I'll just come back to you, and I have your slides up. Let me know if you see, and then I can go ahead and move forward.
Yeah, so let's start, and we can, go to the next slide.
Yep. There we go.
So this quote someone presented to me as part of our government relations work at the Permanent Medical Group. And it kind of summarizes what we do in advocacy. There's only a small number of us that takes the time out to go to meet with our legislators to advocate for our specialty. But that small group of people really do make an impact in terms of health policy and legislation that will affect us for decades to come. So I always think about this when I'm, by myself going, okay, I can't believe, I'm on the plane doing this, going up to Sacramento again. But, just keep in mind, this is the commitment that allows the change that we see to happen. So, for people who are here, thank you for taking the time out to hear, because it really does make a difference. It doesn't seem like it right away, but you will see as you progress in your career, this advocacy does make a lot of difference in terms of allowing good policy to get passed and preventing bad policy from staying on the books. Any comments, Tim, on this?
No, I think you summed it up great.
Okay. So next slide. So part of what we do, and important to keep in mind, is what we try to do is focus on policy. Politics is going to be what it is, and we work with both sides of the party, be it Democrat, Republican, or Independents, so that we get good policy and not get politics involved into it. So that's what we focus on. So, when we go do advocacy, or when I go do advocacy for CMA and for the Permanente Medical Group, we meet with both sides of the parties. Next slide. So this is a definition of what policy is for people who are not familiar with it. Policy is a law, regulation, procedure, administrative action, incentive, or voluntary practice of governments and other institutions. So a lot of things that we deal with on a daily basis in practice. Prior authorization, that's from the insurance companies. There's no laws about prior authorization, but there are laws regulating how prior authorization is utilized. And that is probably one of the bills we're going to be lobbying on when we are up in Sacramento. So we talk about social determinants of health that impacts on what we do, how our patients are treated, and there is policy and even legislation that kind of targets the social determinants which impact on our patients. And I have the Epic logo on there, but that's just a symbol of how AI is, being more involved in medicine. And there's current bills there that are good for what we do in terms of how AI is utilized, but some of these bills are also um, can slow down what we're able to do and impact on how we provide care to patients. Next slide. So these are some examples of what health policy is. So we talk about food insecurity, and there are laws to address that in terms of how we treat access to food, to weight loss. We look at how big pharma can overcharge for medications and how we have regulations on the books to try to control that. One example is the whole issue with EpiPen and how they were overpriced for a while. Another is the law on the book controlling the cost of insulin. So all these are different types of health policy gets implemented both at the state and federal level that impact on how our patients get care and how we're able to treat our patients. Next slide. And then just click it one more time. So when we talk about policy, it's in that purple. Can you click it one more time? It's sort of big. Uh, I guess it doesn't show. So the policy window is kind of very narrow because it's a perfect matchup of when the problems have enough awareness that people want to do something about it, or our politicians are willing to put their time on it. There's a politics, unfortunately, that gets involved in how it gets looked at because there's money involved. There's different interest group, especially when we talk about big pharma, about large insurance plans, and then there's a solution. And not the perfect, but when all three come together, then we can come up with some policy that will work to get something on the books. And we talk about the bills that we'll be supporting. That's how these bills get created. Next slide. So when I talk about advocacy, that's what we try to do when we go out there. We try to educate. So we educate the physicians around us, our staff, such as nurse practitioner, physician assistant, about these issues that come across. We have to educate the elected officials because really they have so much on their plate. They don't understand. They really don't understand the bills that are on there. So it's our job to advocate or educate them so that they understand the implications of these bills that are being proposed. So that's the first part. I think that's something that all of us should do because we know cardiology, we know medicine, we know the problems and the challenges of practice. Once we're able to educate, then we need to advocate. So we advocate both on the state level, that's what we're doing, and also on the federal level when we can. That's why we have our national lobby. And then once the next step is engagement. This is when we take the time out to meet with the legislators, which is how what we're doing next week on lobby day. And it's good for them to hear from us because we're the ones on the front line and they need to hear from us. And the other ways we engage, we have the voter voice, I think, with Tim, where we send a blast and have you send a quick email to your legislator. That's what we do on the national stage so that our voices are also heard because all these email messages they get counted up and that's how it helps them realize that people are paying attention to what's going on. And that's all I have for overview. Tim is going to provide some more granular examples where he's talked about bills that we've lobbied on or lobbied against where our voices made a difference.
Thank you, Dr. Wong. So I thought I'd just give you kind of a snapshot of um, the type of work that I do and what I'm doing on behalf of the chapter. And I just focus on state legislation, so stuff in California. I don't focus on any federal issues, so I don't interact as it relates to CMS or Medicare, nor do I interact with any other states. But in California, there's more than enough to keep us really, really busy. So to kind of give you a sense for how busy it is in Sacramento, every year, there are anywhere from 2,000 to 2,500 bills that are introduced into the legislative session. So part of what I do is I go through those bills and I sift through them, trying to pull out the health related bills that would be of an interest to the chapter. More specifically, I'm looking for bills that have a direct impact on cardiology, on the specialty of cardiology. And then I work with Dr. Wong as the chair of the legislative committee to try and formulate, okay, which bills are we going to focus on in terms of our advocacy? This year has been really interesting because, for whatever reason, there is a large number of bills directly impacting cardiology. So it's been kind of fun to go through those and work with the chapter to figure out a game plan to how to approach those bills. So I'll just mention a couple bills that we're working on this year, and it'll kind of give you a sense for the range of issues that we're seeing. One in particular that was particularly interesting is that there has been a regulation on the California books going back into the 1970s that says that when performing a cardiac bypass surgical procedure, so a CABG procedure, it requires to have three surgeons in the room at one time. And it's interesting because not only is it extremely old, it goes back to the 1970s, but we're actually the only state that has that regulation in place. So when I say we, I mean the chapter was approached by a legislator from Northern California in the very north area, and he thought that this regulation was outdated, so he wanted to run a bill that would change the regulation from requiring three surgeons to only requiring one surgeon. And he was reaching out to the chapter because, as representing the specialty of cardiology, he wanted to get our input and understand what might be an approach that we would be okay with. So it's an example of how the legislature is looking to the organization as the specialist in this area to get feedback. Well, his perspective was in a rural area, as you can imagine, it can be really hard to get three cardiac surgeons into one room at one time. And many times, what they do is they actually fly surgeons in to just be in the room. So imagine you're a rural hospital and your finances are probably pretty strapped, and now you got to fly in a cardiac surgeon for the day to basically be on standby during these procedures. So we were heavily engaged in negotiating with the author. As an organization, we talked a lot about this amongst the Dr. Wong and also with the governors, and we felt that maybe a better first step is to go to a 2-to-1 ratio as opposed to going from three all the way down to one. So that's an example of a type of a bill that comes through in California that has a direct impact on the specialty in which the organization is actively involved. Another bill that we're working on relates to obesity care. So, as I know you know very well, the impact of obesity on cardiovascular health is significant. So, there is a bill going through the California legislature right now, which would require health plans to um, be required to cover at least one anti-obesity medication, behavior therapy, as well as bariatric surgery. So this was another bill in which we've engaged, and we're currently supporting this bill right now, but we're also working closely with the author and the sponsors of the bill to help craft it, and they've looked to us for input on that type of a bill. Continuing down the path of other examples of bills, there's another bill this year that has to do with trying to expand the use of AEDs and CPR in youth sports organizations. So there's another bill which would require coaches and youth sports organizations to be CPR trained, and also to require youth sports organizations to have access to an AED when kids are practicing or during a game. So once again, an issue that's very near and dear to many folks within the chapter, and we've engaged on that one on a fairly heavy basis. And then lastly, I'll mention kind of picking up on what Dr. Long was saying around prior authorization. There are a number of bills this year which are trying to improve the prior authorization process. So this is the process, as you I'm sure understand, is where you're trying to get either a treatment or a procedure approved, and the health plan is denying or they're delaying or they're causing all types of problems in terms of getting that approved. That's slowing down your ability to provide the best care for your patient. So we're working on no less than 5 bills this year. They're all looking at different pieces of that prior authorization process with the aim of improving it, making it easier for you to provide the best care possible to your patient. So just a few examples of bills. I will also mention, in terms of other topics, scope of practice is a big topic in California. You may not know that the states in our laws defines what the scope of practice is for the various healthcare professionals. Specifically with nurse practitioners over the last, let's say, 5 to 7 years, there's been a strong push with the nurse practitioners to have the ability to practice without being under the supervision of a physician. So we've been actively involved in working on legislation along those lines. So I'll pause there for a minute. Otherwise, I have a tendency to ramble on and see if there's any questions, and more than happy to go in any direction you'd like.
Thank you, Dr. Wong, and thank you, Tim, for both providing that overview to advocacy and those specific bills that are of interest this year. We'll take the time to open up the window, open up the floor for any questions that the audience may have. I'm happy to start with a question as well to get it going. You mentioned those 5 bills, or at least those 5 ones that we're working on this year. And it would be interesting for us to hear about any experiences in the past years about successful policies or negotiations that have gone through and the impact of those prior policies that the California ACC has partnered with.
I think that one of the biggest ones that jumps out to me, and Dr. Wong or Leanna would have to help me remember, I think it goes back between 10 and 12 years, is there was actually a push by the radiologists. They were interested in essentially carving out the imaging testing space and basically try to box out cardiology from being able to interpret tests. So for CT and MRI tests, and they actually ran legislation that would have effectively done that, and it turned into a very rare but very big fight within the House of Medicine that was done through legislation. So we were active in working on defeating that bill. So the radiologists had a very strong author that was working for them, and we were able to get in front of legislators and really explain the value that cardiologists bring in terms of being able to interpret these tests and not just having it carved out for the radiologist. So that one really stands out in terms of um, I say fun because we won, but it was a pretty exciting issue that was pretty contentious. And it was one that the radiologist tried a number of times. And when we finally defeated it in a very convincing fashion, they decided that it wasn't worth pursuing any further. So they haven't since pursued that one since. But that was a big win. Um, Another example was, or Rich, did you want to jump in and comment or?
No, I think that's a good one. I remember that one, Tim, and that was a while ago. And actually, it is kind of sad when there's fighting within the House of Medicine, because it actually makes us look weak overall. And it was a tough position to put a lot of physicians in. And I'm glad it got resolved the way it did because it actually really, if you think about it, it became a non-issue these days. 10 years plus, this whole who reads the scan really doesn't make that much of a difference. It just came down to a money fight, unfortunately. And I'm glad it got resolved. I think Dr. Lepore was very key in advocating on saying, look, you just can't say radiologists only read cardiac CTs because that's like saying, only a certain person can read echo, and it created all this hubbub of who is qualified and not qualified to read ultrasound. So yeah, and that's example of bad policy, and it got stopped. And because the radiologists do have a big lobby, and that's where the politics of it gets involved. So I'm glad that got resolved favorably, and now I'm glad that's not on the books because it would be very problematic now. For, let's say, a cardiologist who is trained, let's say, to read cardiac CTs, no longer be able to do that.
Another example that comes to mind was just a few years ago. As you may or may not know, actually cardiology has been very advanced in the sense of being subjected to outcome reporting. It's something that the House of Medicine is very hesitant to do, and I've always been impressed with cardiology has been more open to it if it's done correctly, if you have enough protections around it and enough guardrails to protect against situations where you're not using risk adjustment when you're related to your outcome reporting. So for CABG procedures, that has been in place for years. And a few years ago, the Department of Public Health decided it was time to expand it and have it apply to all PCI procedures. Well, the problem was is that they didn't reach out to us to talk through it in advance. They just kind of dropped this new proposal into the legislature. So the chapter very quickly engaged on it, and we engaged in a fairly deep conversation with the Department of Public Health and one of the other departments that is responsible for overseeing the outcome reporting of the cabbage program. So I think it was a great example where we had the governors at the time and that entered in negotiations with the departments, and we were able to find a place to not necessarily stop the request to do outcome reporting on PCI procedures, but to limit it to TAVR procedures. So I think it was impressive that the organization was willing to engage in this conversation. I think they recognize that uh, to only do outcome reporting on cabbage procedures, especially with the decline in cabbage procedures over the last 10 to 15 years, that it makes sense at some point to work its way into the PCI procedures. But it was another example of how the chapter is getting directly involved in something that has a very broad impact and really designing it in a way to build in some guardrails to ensure that as the department looks to expand its outcome reporting, that there is some guardrails in there. There is an advisory committee that is convened that includes members of this organization to ensure that there is consensus on how to move forward on something as critical as that. And as you can imagine, if you have an outcome reporting program that really doesn't have those guardrails, that may not have the right protections as it relates to adverse reporting, adverse events, then it can have a significant impact on interventional cardiologists, especially in terms of their willingness to do those riskier cases. So that was one of our big talking points, is that if you make outcome reporting um, unbalanced, you're really running the risk of many people not looking to take on those tough cases because of fear of the outcomes and having an impact on their reporting figures.
Thank you so much for sharing those advocacy efforts. It's so interesting to hear about some of the work that's been done and the way that work has directly impacted how we practice cardiology now. For fellows and for also practicing physicians who want to get involved in this area, what are some practical ways that they can start? And especially for people who don't have formal training or backgrounds in policy, what are some opportunities for them to be involved in? What type of, what does a time commitment look like to contribute meaningfully? And what are some ways they can be involved, both in small ways and sort of bigger ways?
So I'll tell you what worked, or my journey through this. So when I finished training, I started in private practice. Um, I was busy, and but I didn't have kids yet, so I was able to have some time to do it. But once life got busy, it became hard, and I stepped back from the organization. I just didn't have the time to do it. I was building up practice, and kids, and but then when I changed jobs at Kaiser Permanente, they actually have a government relations setup. So the opportunity came up 8 years ago where they needed someone at my medical center to do government relations, and the opportunity presented itself again. And once you get started, it's nice when a place has an infrastructure to do it. It makes it much easier. And then my kids are older, have the time to re-engage with the California ACC to start advocating for a specialty again. Um, you can do it in different ways. I mean, you have the time. You work with your local medical center. LACMA, CMA, that's a good way to start. I say California ACC. I think our advocacy is actually really good, much more organized, and at least LACMA. I mean, I know I'm on record for saying that, but I think we are better organized when we go advocate than LACMA. CMA is a whole different thing. They're much more organized, but it's a much bigger involvement. Um, I would say if you look at where you practice, if there's at opportunity, That's always good. I'm not sure, UC Irvine or Stanford have formal government relations department. They may because they need to advocate for themselves too. And everyone's goal is pretty common. It's like delivering care to patients, good quality care. Um, and sign up for the email, whatever, the voter voice that we already have set up. And if you don't have the time, donate to the pack, because pack is where the rubber meets the road, where the rubber meets the road. So I donate to the CMA pack. I hope I donate to our pack, because that's the money that buys you FaceTime with the legislator. And that if you can't be there physically, donate to the PACs that advocate for our specialty.
Thank you, Dr. Wong, for sharing those different ways that we can get involved in the different, both regional, statewide, and types of involvement. That's really helpful for us to know and think about, and you know, helpful as fellows when we may not have the time or schedule capacity to go to lobby day, but then we can send emails as voters or donate what we can as well. From hearing both of your experiences with some of these active legislative issues, it sounds like a core part of the experience is also developing those relationships with the legislators and the authors. And I'm curious how, California ACC and how cardiologists can develop those relationships. And in developing those relationships, if anything has come up in terms of, common misconceptions that the lawmakers may have about our profession and about cardiovascular care and how we can go about providing more information to clarify those misconceptions.
You want this one, Tim, or?
Yeah, I'll take a crack at it. You're right. So I think one of the most important things that the organization can do is to develop those relationships with the legislators. So we always encourage folks to reach out to their local legislator, invite them into your practice or your program. They love legislators, enjoy taking tours, and then they really do enjoy getting connected with their constituents, especially local physicians. So my experience is that when we can get a cardiologist connected to their local legislators, we're able to kind of develop that relationship. Um, in the spirit of full disclosure, that admittedly doesn't happen very often because, as you just mentioned, you all are a little busy. So carving out time like that can be a challenge. That's why lobby day becomes something that's helpful because when you come to Sacramento, then we can get you directly in front of those legislators. But once again, understanding that it's hard to take a day and come up to Sacramento to do that. There are some other ways to do that, and I know we're trying to explore other means to get connected with legislators. And kind of going back to the previous question, if there is an interest in this area, I would also encourage folks to join the legislative committee. There really aren't many meetings. Rich, there's probably maybe two or three a year. But in those meetings, we talk about legislation in more detail than what we're doing tonight. And also, I believe Leanna puts out some of the legislative reports that I send out to the governors and to the council members. To the extent that anyone's interested, we can make that available to the fellows as well. And in my reports, I go into a longer list of the bills that we're advocating on. And my experience is people see that, they get intrigued by it, and they kind of gravitate towards that as a result of seeing what's out there. So I know I kind of strayed away from your initial question, but I just wanted to throw that in as well.
So I'm going to say this, that Tim has been very key in helping us build this relationship because he's up in Sacramento. He's meeting with these people. He knows the relationship. He knows the history. And this is, you know, the depth of work that he's done or the duration of work that he's done for us really helps because it takes time to build these relationships. Because, you know, as part of the government relations for, Permanente medicine, having that structure allowed me to build these relationships. And it took a lot of time. It took many years attending events, getting to know the local officials at their events. And so that now, I can reach out to one or two of my local legislator very easily. And it's a combination of issues. Is they're in your area. They may have family members, friends who will go to your area to get their care. And once they know that you're available, you build that trust with them. So you can, they have someone at the hospital, they go, oh, okay, this person, I know they will make sure I get the extra attention that I get, the extra need, so that you put yourself out there. But that's how you build these relationships. You make it personal, and when you need something, you go, hey, could you help me on this bill? This is really not good. At least hear me out. And these legislators change because of term limits. So I'll give you an example. Luz Rivas, who was a state assembly member, she lived in Panorama City. We had a good relationship with her. Now she's at the state level. So all the years of cultivating that relationship, you know, not going to help us out at the at the state level anymore. But that's the whole process. So it's a long term issue, but it's worth it because when you need help for something, at least you at least have their ear. They may not completely agree with you, but you have their ear, and hopefully that will influence how they vote.
Thank you for sharing that information on how you forge relationships with the legislators. Can you also share a little bit about like who brings these issues to your attention, and once the advocacy or the issues are brought up, how do you determine what to prioritize each year, and how do you strategize or figure out what process it will be needed to move those issues forward?
When you say issues, are you talking about like bill ideas or what? Can you, I'm trying to
Yeah,
figure out it. I might answer it one way and Dr. Wong might answer it a different way, depending on.
yeah, either existing bill issues that will impact cardiologists, or issues that cardiologists bring forward that they think need to be addressed, such as, for instance, the cabbage one that you shared with us earlier.
Um, Ideas from legislators or ideas that end up in bills kind of come from a couple different places. Organizations like California ACC could say, I have an idea for creating a new law or changing an existing law. And then the chapter could then try to approach a legislator and say, hey, we have this idea. We want to change the cabbage surgeon coverage from 3 to 2. So that's one way that ideas end up becoming laws. And the legislator could say yes or no. So let's assume they said yes. Um, so you have all different types of advocacy organizations that are out there that are reaching out to legislators with different ideas on new laws or changing existing laws. And as those ideas are introduced into bills and introduced, I will see them. So on my side, going back to what I mentioned earlier, so there's 2,000, 2,500 bills that are introduced. So then I go through those and then try to collect the ones that I think have the most direct impact on the organization and on the specialty. From there, I reach out to Dr. Wong and I send him a list and say, okay, this is what I've found for this year. And then Dr. Wong helps me organize them in terms of priority. And then the next step would be to reach out to the entire legislative committee and get feedback from them in terms of which are priorities, and not only what are the priorities, but what position do we want to take. And it gets a little bit nuanced from there because there could be things that we like about a bill and things that we want to make changes to. And I'll give you one quick example from just this year. So the obesity bill that I mentioned, there were some aspects of it. There was a different bill that was introduced than the one I described to you. And the other bill was different in the sense that it required health plans to cover GP1 medications. And the discussion internally was is that okay, that makes sense, but does that make sense for every single person who is meets the definition of being obese? So the discussion kind of percolated largely from the governors, Dr. Wong and John Baker, and the discussion was is that it might make sense for those who are at that moderate to severe level. So we discussed about asking for an amendment to that bill, and then that was led to us taking a position that was asking for an amendment. So we worked with the author to try and get that amendment. So that's an idea, or that's an example of um, how an idea becomes a bill, and then kind of how the organization can engage and get involved and make adjustments to things.
Yeah, I mean, I agree with what Tim said. I mean, it's multiple levels. I think, and Tim, you go through all the screeners, right? So everything that comes out, you have a way of screening the health related bills that will affect us, and you kind of pick through all those, which is a lot of work. Is that correct?
Yeah, exactly. So just kind of sifting through those bills, and I mean, it takes a lot of work, but it's, for having done it for a while, it's pretty easy to cut through all the education bills and all through the transportation bills, and just sift and just get to the health bills. Um, but it's unique because California is very different than at the federal level. There's very few issues that go through at the federal level compared to California, where we just have, you know, 2,000, 2,500. And I think everyone would agree that's way too many, but that's where we're at, and that's kind of my role to help out there.
Thank you guys
Yeah,
both for walking us through the process. It helps demystify the black box of what happens when these issues
it
come up.
doesn't get any easier. It really is like making sausage when you talk about it. Because when you look into the nitty gritty of all this stuff, you don't know why it's built that way. It actually doesn't make sense. And some of the legislators, especially the junior ones, they put up bills that you're like, why are you doing this? Do you understand the long term implications of this, and
Mhm.
how it's going to change things? And it really is difficult, especially when the state has a budget issue and they want all this stuff, and you're like, how are we going to pay for this? What does this mean? Is this something that's going to be passed and just be ignored, or what's the long-term consequences of this? So it's actually very it can be very challenging, and that's why we're here to do what we do. We don't get a lot of praise necessarily, but it's making a huge difference.
No, definitely hearing both your stories, I feel like just hearing about the implications from that radiology uh, bill that came through, I didn't even realize that that was something that was up for discussion because at this point, we almost take it for granted that we're doing cardiac CT training in our fellowship and we're going to courses, and it wasn't so interesting to see that so much of this discussion in the background can really impact how we practice and what we're training for in the future practice as well. Oh. And question that I think of when think about the future is, are there any emerging issues that you both can foresee upcoming that would really impact policy and how we practice cardiovascular care in the upcoming years? There's so many new things that are happening with AI and telehealth and obesity medications, like you mentioned. So I'm curious if you can share what you have what your pulse is on for the future.
So
I
I
think
think
Dr. or Rich, I was just gonna say I saw Dr. Wei had her hand up. I didn't know if she wanted to jump in and add on to.
Oh, I think the question is very pertinent to what maybe I can add. So go ahead, Rich. You're going to respond to that now, add on to just some personal experiences from just
no,
last couple
go
of years.
go ahead. We've been talking a lot. You need to talk too.
Well, no, I just wanted to say, thank you guys both for sharing that. And I agree, Tim, the work that you and the Government Relations Committee does really makes a difference. And that's what we don't often realize is just that relationship, having that relationship, really being there to answer questions that are pertinent to our cardiovascular practice is important so that it can direct our future practice as cardiologists, our career as cardiologists, but then, of course, for our patients. And it can be very subtle, making little changes to the way prior authorizations are approved, such as just extending the period in which expirations last. That's something that is going to be on our discussion table next week, to something so drastic like the 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 practice of reading imaging, cardiac imaging. And you never know what will come up, but I'm just so appreciative of, our government relations chair and Tim for helping us walk through that, because I came into California ACC without any advocacy experience. I was not engaged as a fellow. I was not engaged as an early career. And it really wasn't until more mid-career that I, got to understand a little bit more about what was going on. And then you really see the value of contributing your experiences to these legislators who may have some, limited experience because they had the ear of a patient or an ear of someone who, of course, is going to be to have some bias, regarding whatever position they're trying to make changes for. But being present and being able to, whether it's those, voter emails that you'll see in your emails when we want your opinion, help regarding a particular bill, like Prop 35 last year was something that we were really trying to push out just because it really affected ability for cardiologists to even see Medi-Cal patients because the reimbursement rate had been so low. We really wanted to protect the patients to be able to be seen and to allow more cardiologists to see Medi-Cal patients. So those are, different ways that you can be involved with as a fellow. But as you move throughout your career, and if there are certain inequities or certain challenges that you are facing in your practice, do keep us in mind, because there are things that we will be fighting for that have some play in your daily practice, or at least your monthly practice. And could be lobby day that you decide, you know what, I'm going to come in and share my personal experiences if there's a particular bill that really relates to you. I think, Evelyn, when you went to Ledge Conference, there were also national bills that were relating to like sudden cardiac arrest, and our fellows who, you all who are in the midst of coding patients, seeing patients coming in to your ICU and your ER with, really poor brain function because they didn't get quick ICD care. Those are real life experiences that you're able to share. And the legislatures up in DC or in Sacramento like to hear those type of experiences, because then they can put a face, to what they are trying to deal with, and trying to, they're faced with so many bills, right? And so you want to kind of give that patient story that really makes an impact in their memory.
Yeah, I think in terms of legislation coming up, I think financially, I think the whole issue with Medicaid or Medi-Cal is going to be an issue. It's how to get funded. It's much more negative than we expected. And if Medicaid gets cut by the president, then it's going to impact Prop 35 and how much we will get reimbursed from Medi-Cal. And that kind of is concerning, because we put in a lot of effort to get Prop 35 passed at CMA and all the other medical societies with that hope in mind. So that is actually immediate effect, because it affects our patients, physicians, so that the physicians who take care of Medi-Cal patients should get reimbursed fairly. So I think that's a big impact that we can see coming up in this year, next couple of years, fiscally. And the other thing maybe down the line is how they regulate AI in the state and how we use it. AI can be good, and it can be bad. And AI is good. For example, I use a bridge, which is a transcription technology, so that I don't have to type as much. It transcribes the patient's visit. That's the type of AI as far as the state is concerned. They want to kind of control, there's bills to try to limit its use, which I think is negative, because it's not really AI in the sense that it's doing all the work. It's just transcribing. I still have to edit it. But then there's also these chatbots that come off as psychiatrists or psychologists that people are using to go over their mental health issues. Now that is a little different, and that probably needs to be regulated. I think it's a bill that has to deal with that. So those are the two issues I think is going to be big issues for medicine, not just for cardiology, but just for the House of Medicine.
Thank you both for sharing that insight. The AI issue, I feel like, is going to be a pressing and interesting one to see evolve in the next few years, and as we emerge Nari ourselves and other fellows into practice. We're coming close to the top of the hour, so I just wanted to leave some time if Dr. Wong and Tim have any final comments or if there's any other final questions before we close off.
I'll just say that it's understand when you start practice, finish up as a fellow, that's a lot to take in. You don't have to do a lot at once. Just trying to find a little time to do it, and you're interested in it, pursue it as time allows, and ask your organization if you work for a large organization. See if they have a government relations, I say department or just some government relations people who will help you out with it. So that way they can provide the infrastructure for you to meet with the elected official. And if they have someone who works in communications, works in government relations, they would be glad to glad to have your assistance because it's not easy finding physicians who are willing to put themselves out there to meet with the legislator. And I will say that you all know medicine, you all know cardiology. Um, at the end of the day, meeting with legislators is not that different from meeting down with a patient. It's about building trust and getting your views across to them and have them come to agreement so they will understand what you're recommending.
I think those are great final words. I don't want to take away from that.
Oh,
If
come on,
there is
Tim. You
any,
you, you have so much
no,
experience
that I
lobbying.
wanted you to have the final word. So, but if there is anything of interest that jumps out to anyone, please reach out to Dr. Wong or myself. And if you see some mention of a random bill or some issue that kind of piques your interest, just reach out. We want to engage you and help you. And I agree. I think the AI area is going to be fascinating to see it play out. And the states legislators don't necessarily have a lot of knowledge or experience in that area, so it's going to be really fascinating to see how they try and navigate it. And I think they want to put some guardrails around it, but doing it in a way that doesn't stifle the use of it or the development of it. I think is going to be um, it's going to be a tough one to balance. So I think there'll be a lot more to come on that.
Yeah, so more opportunities for us to get involved as well if there's anyone interested out there.
You
Yeah,
could
for
you could
sure.
run for office. I mean, one of the
Yeah.
cardiologists at Harbor UCLA is running for a state senate. So,
Um,
um, you know, if you have that interest, that's you can do anything you want.
the sky's the limit, and we definitely need everyone to be involved, whoever is interested.
Yeah.
Yeah,
I say
well,
join the government relations committee first, then run for office.
right. And
Yeah,
with
that's how I started. Roy, who's Harvard, he started with LACMA and then CMA, and that's how he's got to the point he is now, where he's running for state office.
And I see also Dr. Way has copied the link for the advocacy page at California ACC. And on that website as well, you can navigate to the Government Relations Committee page for further details. And with that, thank you everyone for attending. And thank you so much to Dr. Wong and Tim for both all the work that you guys are doing to advance advocacy for cardiovascular care and cardiology, and then also for your time and sharing this expertise with us today. It's been a really high yield, informative, inspirational session, and we appreciate all the interest and all the expertise and motivation for us as fellows as well.
Well, thank you for setting us up. I know fellows' schedules are busy. Thank you to all the fellows who showed up. I know you all have busy schedules too, because you guys are finishing soon and can't wait to finish your fellowship and move on to the next step, right?
That's right. Yeah.
Thanks, everybody.
Yeah,
Thank
good
you.
luck to you all. And don't forget to apply for FACC.
All right, and we'll see you
Okay.
next week.
Bye. See you guys
Bye,
next
everybody.
week in
See you next
Sacramento.
week.
Yeah, looking forward to it. We're gonna have fun.
Bye.
Bye.
Bye.